everyone, and welcome back to the Byolete podcast, the podcast where we discuss the science behind the brand. So, before this podcast, we've just literally had about an hour and a half, I would say, conversation or debate.
I'd probably say longer.
Probably longer, and we should have recorded it. We were talking about a lot of things, mainly about the food industry and the consumption of ultra-processed foods within the Western world, and debating who was to blame within that, whether it was the, government or the big corporations, or whether it was an individual's sort of own prerogative, whether they were going to take it or not, or consume it. And so we will try and maybe get a bit of that into this podcast, because I think it was a really interesting conversation. And even if we don't maybe talk about it in this one in great depth, which we probably won't, we probably should do another podcast on it, because it was quite interesting.
It was. We should have filmed it.
I know. But for this podcast, obviously the title of it is that I don't believe in statins. Kind of a little bit of a clickbait, so sorry about that. But the thing is that this is a conversation that I personally had with somebody over the weekend. And actually, if I'm being completely honest, it's a conversation that I've had with many patients over the years since I've been qualified as a pharmacist. We, speak to at least about 2 patients on a weekly basis personally, I do, who will decline statin for the treatment of lowering their cholesterol. And I just wanted to really get into with each other why we believe that to be. What are the reasons for why people are declining statins? And so, I just thought it might be an interesting topic to discuss. We obviously haven't discussed this at all. So this is just, again, we're just going to do this off the cuff and just decide, or just, talk about it. So what are your thoughts about why people would not believe in statins?
I think where we're going to get to is the fact that it's not that they don't believe in statins, it's that they don't believe in the whole process that surrounds what makes it someone be started on a statin. So we attended a fundraising event over the weekend in a local park, and the person come up to you, I think, and they were saying that their cholesterol was high, but they didn't believe they wanted to go on a statin because the doctor said this is what you should be doing. And I think it's surrounding the whole process of how a person is started on it, not necessarily that the statin is ineffective or they don't believe it. Because statins have got a really good evidence base. And I always say that to people because I think it throws a lot of people off when we speak to patients on a weekly basis. I would say in the region of 3 to 5 people a week. And I say, if push comes to shove and I need to go on a statin, I will, because they're highly effective medications. Yes, like all medications, they come with side effects, because in reality, if we were just left to our normal physiology, we'd probably be dead if we didn't use them. So there's got to be a trade-off for that benefit that we're getting. Yeah. But they are highly effective. But I think it's surrounding the whole process.
I agree. And that was actually part of the conversation that I had with this guy. So basically, he'd said, I didn't believe in statins. And I said, oh, okay, well, why is that? And he said, I just don't. So he couldn't really give me an answer other than that he just didn't believe in them. And then when I said, okay, well, what was the circumstances around you even having a conversation about a statin? He said, well, I've been diagnosed with high cholesterol, but my good cholesterol is high, so it's fine. And I said, okay, well, what did they tell you to do then in order to mitigate your risk? And he said, well, they told me to eat a low-fat diet, but if I do that, then it's usually foods that are high in sugar, which, is correct. If you're eating, or if you are looking for foods that say low-fat on them in the supermarket, more than likely they are ultra-processed foods, and so probably do have a high amount of sugar. And I said, okay, and what else did they say? And then he just said, they just told me that my good cholesterol was high, and so, to keep eating or to keep that up. And so that his risk wasn't as severe as what it could have been. And so I was just like, well, there's a few things that really are standing out to me there where it's, I don't believe in and I don't agree with. And then the last thing that he said was the person who had told him, so the health professional, was overweight themselves. And he said, they possibly would have had high cholesterol, and clearly they were not sort of taking their own advice in terms of eating a healthy diet. And again, we've discussed this on the podcast before, where it is that what we're trying to do is sort of bridge that gap. So bridge the gap in terms of knowledge. So actually, we don't really get taught a lot about lipidology into the depth that we should know.
No, it's just basic lipidology, isn't it? Yeah. Total cholesterol doesn't tell you what it's doing and what it correlates to in terms of risk. But definitely a big gulf in education. And then also we're trying to bridge the gap. I think what you're going to go on to say is in terms of if the advice and evidence is so compelling, why aren't healthcare professionals doing this? So that's why we lead the life we do. We vlog it, we put it online to show people that at this moment in time, this science is correct. It may change as does everything until it's proven otherwise. So that's a big thing. Was that his first cholesterol test?
So I didn't ask him. And then obviously what happened after that is that I sort of, well, okay, you know, if your cholesterol is high and it's significantly high that it needs a statin, then I would not discount a statin altogether. I'll go away and do your own research, because like you've just said, you know, they are really effective medications at lowering cholesterol. They're not the only medications also that we have. And so if maybe a statin is not something that you want to consider, there are newer medications now, like PCSK9 inhibitors. Potentially you may not be able to get that on the NHS, but that's sort of a whole separate point. Or ezetimibe, which you potentially could look at. And I think my issue with the whole consultation of what he described to me was that it probably wasn't really that in depth. And I think if the health professional is not given the full picture of what's actually going on, or what the options are, or why we actually give statins, or actually a robust way of actually reducing your cholesterol, and given, you know, not just a comment of saying, oh, we'll eat a diet that's low in fat. Well, what does that mean? I think if we become more robust in being able to deliver that information, then I think it just makes the patient feel a bit more, okay, well, these clearly know what they're talking about. And, you know, it may want them or prompt them to then think, okay, well, a statin may be something that I should consider. Yeah.
There's a few things that I've looked at recently. You listened to something before we done this podcast, and it was with, what's his name? Tucker Carlson.
Yeah.
And they were looking into the pharmaceutical industry, and there was a lead doctor from Harvard or Stanford who qualified, and she left their health system to go and work in preventative health. I've seen it a few times on LinkedIn where a lot of doctors, pharmacists, whoever are leaving the NHS to go and pursue preventative health. And I think that's where we stand. And this is why this whole consultation brings something else close to home, is that we didn't go into healthcare to treat a sick population and not we didn't want to leave what the cause was on the table. We want to investigate everything. And that's why people might say to us, oh, how come you're leaving this body in terms of the NHS? Why are you going down this route? And it's because of things like this. So this gentleman's come in to see you at a park, by the way. We don't know whether that's his first cholesterol test. And the first interaction he's had in the health system from this point of view is treatment. And let's not beat around the bush, poor advice. Because of a lack of education. Because yes, a lot of healthcare professionals are really good at pharmacotherapy and interventional medicine, which is good, but we're not good at preventative medication.
We're not. And the reason being is that it has nothing to do with the health professional individually, I don't believe. And we were also, this was part of the debate that we had before. Yeah, obviously we did say that there is a plethora of information out there, and if a health professional wants to actually know more about a condition, they have full access to it. But if we look back at what we got taught in uni, it definitely was it just was not. Preventative health was just like, I can't even remember being taught maybe like, I don't know, like 2 hours on it. Maybe we did, but I can't remember. It was more to do with pathways and guidelines, and pharmacotherapy was the main. Well, obviously we did a pharmacy degree, so pharmacotherapy is going to be the main reason as to, you know, as to what we were talking about. But I think it was even the same for doctors from what I've heard.
Yeah, I think they have less than 5 hours of healthy lifestyle. You want to call it that.
And I, you know, I think it is because, like you say, we are treating a sick population, but I do think that there's a lot of money in pharmaceutics, and so that's not the sole reason. I don't believe that. Like, you know,
I think a lot of people need to take accountability, and that's where we disagreed before, is that I think, yes, people who are higher up in organisations do have a lot more onus and accountability because they've got the intelligence, they've got the resources, but also it fundamentally comes down to accountability from, in this case, the healthcare professional. So that person who consulted with that patient, they should know enough physiology to then be able to intervene and give them the best level of care. Like, we obviously at some point, I mean, me from the age of 18, I cut out all the bad stuff. Not that I was ever overweight, I've always been slim, active, but something in my brain said, okay, this is before medicine, I need to look down this route. We've then gone about it. And I said to you before, one thing that you don't do is give yourself enough, how would you put it, encouragement, and you don't give yourself enough credit because of the things you've done.
Yeah, no, I do, and but what my point was to you before, so we were sort of debating whether the fact that people consume so much ultra-processed food and it's so ingrained within our society was, okay, well, it's there, but people have the choice whether they have it or not. My argument was that, yeah, although they do have a choice, I think subconsciously, because it's ingrained within everything, whether it's on a billboard, whether you see it on social media, whether you see it in the movies, if we're talking about alcohol, like, it's completely glamorized, again, even ultra-processed foods. I would never, unless I looked into it and Dr. Chris Van Tulken brought the attention to it in the mainstream, I really didn't know about ultra-processed food and what the detrimental effects of it were until that was brought to my attention. And I was thinking, I'm a health professional and I don't know that. So if people are not in the health space, how are they supposed to know that? So my argument was, I think that it's so subconsciously there that you could never believe that the food industry or the government would be giving you something that could be that detrimental to your health, that, well, it must be good. If it's being sold in Tesco, okay, yeah, we know that it's unhealthy, I might put some weight on, but it's not going to contribute to autoimmune disease or the depression that I've got. And your argument was that actually you believe
I've got a few arguments against it. So obviously in this case, the patient declined a statin from the doctor. So in that consultation, I weren't there, but I'm guessing the doctor said this is going to reduce cholesterol, circulatory cholesterol, reduce your chance of heart disease, and all these things. Very rarely would he put forward any risks. And the statin use, like I said, is really effective. But this patient's chosen to go against one of the highest people in society, really.
Yeah.
But then when it comes to, what was the thing I said about the subconscious? It was to do with drink driving. So I said, I don't drink anymore. Haven't drank for 2.5 years. But when I drive down a motorway, see a billboard, it's on adverts on the telly. Do not drink and drive. It causes death and harm to other non-road users. I know people within my family who've died at young ages due to a drunk driver hitting them. But then you still see countlessly the amount of people who drink drive because they consciously chose to do that. So my whole argument against it was pharmaceutical industry and all these people who are high up in governing bodies who dictate guidelines and put, like in low demographic areas, put takeaways, chippies, whatever you can think of, all unhealthy choices instead of putting gyms, wellness centres, that people will consciously still make a decision against that. I don't think it, you said it was 80-20.
Yeah, I think 80%, it is.
I think it was more 50-50 or 60-40 with the government having the larger blame, but only disproportionately.
Yeah. I guess, we will debate this at some point maybe on the podcast.
Of course we will.
I think that brings me then to a point that I wanted to make, in the sense that, so a lot of people come into us, like we said at the beginning, and say, oh, I'm not having a statin. And their argument is, or the reasons for why, in my own experience, has been, well, I've seen it on the news that it says that it can cause muscle aches, for instance, or my friends said that it, they tried it and it wasn't good for them. And then usually the root cause of the friend not really being into it was because of news or the media.
Of course, the media narrates a lot of things.
Yeah, and so really I was just having a look to see, well, actually, so I said before the podcast we started, I said, I'm going to, in the middle of the podcast, actually just Google statins and then just put news and see what come up. We actually did it before we did the podcast because we were sort of debating it before it. And actually, all of the articles that have come up, so the first, let me see, 1, 2, 3, 4, were really positive. So lives could be saved by statins. Taking statins could slash dementia risk. Unhealthy lifestyles trigger record 3.8 million statin prescriptions.
Slash dementia risk?
Yeah.
No, a few months ago they were going the opposite way.
Well, so statin heart drugs may also slash the risk of developing more than 20 cancers. So they're all, like, pretty compelling, evidence or pretty compelling articles.
Yeah.
Now, in my experience, I thought it was going to be bad, to be perfectly honest with you. And I was looking into it because I thought, there was a point within my career where the overwhelming articles were bad, and then I look back and it was. And so in 2013, it was, the BMJ actually released an article which was basically saying that statins were being overprescribed to patients with low risk of heart disease, and that the side effects were worse than previously thought. And after that, I think there was a massive reduction in the uptake of statin therapy. So then in 2016, an article was then released in The Lancet, which questioned the BMJ's claims and accused the journal of causing measurable harm to public health. Okay. And so I think that argument of sort of who's to blame, and, I think, not that I'm saying anybody's to blame, but obviously we did see a huge decrease in the amount of people uptaking statins because of the rhetoric that was being pushed
we did, but then there was also a big push for the nocebo effect, and the fact that one of the biggest reasons why statins weren't prescribed to people was muscle pain, myalgia, and then it was actually proven that there was a nocebo effect, which is, for those who don't know, it's the inverse of the placebo. So if you tell someone that you're going to have a negative effect, there's more than a likelihood that you are going to develop that. So muscle pain is a known side effect of statins, but not to the rates that it was perceived to be.
Yeah.
So that's why there was a big push actually for that nocebo effect. But I remember a time, when, my own dad, I was going to say, I hope he doesn't mind me sharing it, but I'm going to share it anyway, is that he went on a statin.
I think he didn't even try it, from what I remember.
I think he did. I think he'd done it for a week, but he used to go to the pub, obviously, where a lot of wealth and wisdom is brewed, shall we say, and someone said, if you just say you've had muscle pains, they'll take you off it. And that's what he done. He went on a statin. It wasn't the best statin at the time, simvastatin, but I think this was 5 years before he had a heart attack.
Yeah.
So it could have reduced the actual magnitude of his heart attack because he ended up having the worst grade, which was a STEMI.
Yeah.
But yeah, he stopped it because of the negative news around at the time.
Yeah. But I think it's interesting, and
it is. But I think the whole point of this podcast, you said it was unfortunately like a clickbaity one. It is and it isn't. Is that person didn't believe in it. But then this is why we have gone so, how would you put it, like a full force into preventative health, is that if this patient would have had the right information and the right counselling 10, 15 years beforehand, through means that he should have had access to because he was a taxpayer, he wouldn't be in a situation he's in now where he's playing catch up, where, yes, his cholesterol's high. Does that tell us too much about his physiological situation? Probably not, but we don't know whether there's any calcification. Whereas if we would have told him 15 years ago, hey, Mr. So-and-so, if you avoid this, do this, increase that, there's a good chance you'll mitigate this risk. Okay, good. I'll put in our measures now.
Yeah.
And that's where we come in, and that's where, because this original podcast we decided yesterday, before we changed it last minute, was going to be, where does Byolete fit into the health model? So you'll see people who are diagnostic and want to intervene with pharmacotherapy. So you go to basically like a hospital where you go and acute conditions are treated with acute medications. But we want to be in between, where if you go to a GP now, it's normally too late before you can be seen. You're not being seen for a health check until 45, 50 for bowel cancer, breast screening. We want to be seen ideally 20 years before then, when you're starting to develop these chronic conditions. The one we specialise in, cardiovascular,
especially heart health.
Which is heart health, which is a disease that manifests over 2-3 decades at least. I looked at something before where there was a 15-year-old girl who died and a 19-year-old lad through a car crash, both of them. Again, they had evidence of fatty streaks within the arteries. And we're thinking, it's happening 2 years before it manifests as a heart attack. But it couldn't be further from the point.
Yeah. And I think I want to just end on the statin debate, is that from the evidence that I've seen, I'm pretty sure that you feel the same, they are highly effective medications. Obviously, as with every medication, there are side effects to them drugs, muscle pain being one of them. But like you say, a lot of patients who do develop muscle pain, it is a nocebo effect. There is a serious side effect. Yeah, obviously you can get muscle pain with it. But I think like you say, there is a serious sort of, what would you call it? A serious side effect called rhabdomyolysis, which is the breakdown of muscle tissue. That is serious. That can be caused by a statin. However, there are blood tests that we can do in order to test that, and so it would be ruled out. Also, if you stop the statin, then most of these things will just reverse. And so I think,
and also, if anyone is on a statin and they do receive any cramp or any muscle pains, we're not saying to ignore that.
Yeah.
Go and get it checked, like you just said. Then you can do a blood test, creatinine kinase. You can do your liver and kidney to see whether it is this rhabdomyolysis. If it is, we'll stop it. But if not, it could be related to something else. But I can't even think of what I was going to go into then. But the point was, I'll let you carry on because that's not where I've interjected.
So they do come with side effects. There are also other medications that are on the market that can be used in combination or can be used as an alternative to statins. And but I do think that, like you just said before, the most important thing and what we are trying to do is say, when you're 30, instead of waiting until you're 50 to go and get your health check, get it done when you're 30. Because even if you just know what your risk is, it's just giving yourself that extra ammunition to be like, well, okay, I know what my ApoB is. Depending on whatever the level comes back at, we'll obviously guide people on what it should be, where you should be at. Again, we're not diagnosing anything, we're not telling you to take anything, we're just simply informing you, and then you are able then to make an informed, educated decision on what you would like to do going forward. If you do nothing, then that's perfectly fine, like that is completely up to you. But if you decide, actually, well, my risk there is too high, that's not okay for me personally, then you know there are things that you can do to mitigate it.
Yeah. The point I was going to make actually was going on about the post we made today. So we put up something about our behaviours and morals and ethics of the business. And then we just went through the pharmaceutical industry to some extent about, is it cloud and judgment over people's decisions? And our role as this company is to try and make a moral, ethical company that we believe in.
Yeah.
So we will disclose anything that we've got affiliations with. At the moment, we have no affiliations with any pharmaceutical company or any supplement company. At the moment, I take no supplements, haven't ever taken supplements. The only thing I used to supplement was protein in whey, which I stopped in October 23. I don't take anything else.
Same for me.
Same for you. You don't take anything else. And we want to try and, you said before that people have an inability now to make an informed decision because of the wealth of misinformation. We're trying to break through this misinformation by providing what we know, what we believe in, what we practice. And I think that was the big point that I wanted to get across, is that we're not trying to coerce anyone into anything.
Of course. And if it come out tomorrow that statins are absolutely horrendous,
we would tell everyone that it was horrendous.
100%. Yeah, you know, we just follow what the evidence says. We make sure that we're checking whenever we are looking at this evidence, who is funding it. You know, that is a big thing. And yet, you know, so far, you know, the evidence suggests that. In fact, I was saying this today to you in terms of we were looking in actually to understand what optimal value should be of certain markers. So today we were looking at ApoB, and it was actually really difficult to find because ApoB is not commonly used. However, Peter Attia, who we've mentioned again before, is a doctor from America who discusses a lot of the stuff that we do. I was reading his book, and it was basically saying that ApoB should be as low as possible. So we should be getting LDL-C or non-HDL and ApoB down to as low as we physically can. So I think ApoB, is it like around about 30? Is that what we should be aiming for?
Well, the guy, less than 55, less than 55, but ideally the lower we get, so like around the 30 mark is really good. So
around 30. However,
milligrams per deciliter, that is.
And then for LDL-C, it was saying 20 to 30 milligrams per deciliter.
Basically the same, it's meant to be a cross comparison.
No, I was saying to you, I don't think I've ever seen that with someone being not on a statin.
No.
I've never seen levels at that low. And so, again,
that goes down into another conversation. So we were saying, why are we going for these really low levels that have never been seen in physiology in the modern day? And it's because years ago, cardiovascular disease, heart disease, however you want to term it, was not the primary cause of death. It was maybe trauma and other things, disease through infection. But now, because we're leading lives into 80s, 90s, dementia is a disease that's more prevalent than it's ever been. So it's a concern for us, but it wasn't years ago. And that's the same with heart health. So if we can reduce it down to them levels, that comes off the table. A new disease will replace it. It might be that cancers increase again because people are living to 100 years old, where cells are needing to turn over at rapid rates, uncontrolled cell death and regeneration. But
yeah. The point that I was trying to make was
I
that
just went off, sorry.
If obviously the evidence is suggesting that it should be that low. If I do everything within my power, within my diet, within my lifestyle, exercise, etc., and I can't get it down to that level, then I will sort of go down the route of maybe pharmacotherapy, because that is the only, like
well,
I
it's
say,
been proven. We went through the results before, didn't we? Through statins and all the other inhibitors, and it reduced it to the levels that we needed to be.
That's what I mean. So I would personally go down that route, and so the point is that I'm never going to tell somebody to do something that I wouldn't personally do. That was the point that I was trying to make, basically. And like I say, I've never seen levels as low without pharmacotherapy. So which means that if I have to go on pharmacotherapy to get to that level, then I will, was the point.
And another point, going off the business idea and morality, is that yes, we are opening a business. We do intend to make money from it. But in terms of our overall goal is to really just swap our current job for this job. So if we're not asking for anything more than that. And I think it's important to disclose it, because people might be thinking, oh, well, are they just trying to drive traffic to this to make an obscene amount of money? Don't get me wrong, if we got more money than what we're getting now, that is a bonus.
Yeah.
But we just want to supplement, or basically switch our income. We want this to be our primary income and that to not be.
Yeah.
And when I mean that, I mean clinics. We will still have a hand in clinical practice, but not to the extent we do. And one way that we're trying to break down these barriers to health and wellness is that we're going to start run clubs or events where it doesn't have any financial boundaries. So if we go for a run club, for example, which are popular at the moment, the one thing that you don't tend to see, apart from very few, we go to actually one who does abide by this, is that we're going to offer coffees on us, so that no one feels there's any resistance to them turning up. And we're trying to break down every eventual barrier that allows people to get the best healthcare and best wellness that they actually need.
Also, another point on that is that most run clubs that we go to are 5k, and I feel like that's a really far distance for anyone to run, and so ours are going to be around about 2.5 to 3k. Again, it's breaking down the barrier of, okay, well, 5k is a bit too much. Well, don't worry, because it's not going to be that far. Like, that is like, I think we were saying this actually the other day, just to go a little bit off topic, in terms of people running marathons. It's so popular now, and it's everybody's doing it, that the actual achievement of it is downplayed, because like, oh well, you've seen like 60 people do it, over the last week or whatever, and yet that's an unbelievable feat to run a marathon. 5k is unbelievable to run, but everybody does it now, and so it's about saying, like, even just getting up and going for a run is unbelievable, no matter how far you run. And so that's why we want to make it accessible for everyone.
It is. When you listen to that podcast before about the American doctor, the stats they come out with,
it was
so
scary.
Social media clouds everyone's judgment. So you're looking at the top, I don't even know what percent, probably 1%, probably even less, of these people who, like you just said then, a marathon's not even a feat anymore. It's something that people do just on a Sunday morning for boredom. But in reality, 50% of US adults had pre-diabetes or diabetes, and 74%
of adults were overweight or obese in America.
The population of America is, give or take, 340 million.
I think it was 50% of children as well.
So let's say, at least 2 of the UKs within America are obese or overweight. So that just shows what you see on social media, and all these things are very few percentiles of a population.
I think it was saying as well in that podcast, which is so true, if we look back to 100 years ago, it was, if you were overweight or if you were obese, you were in a circus, because it was that you just didn't see it. And we've somehow, well, we know how, but from that point until now, it's the norm. Like, if in fact it's that normal,
it's the opposite
that
now,
it's the opposite.
Where if you walk in and you look trim,
it's like, wow, and it's.
I heard someone say it the other day, and it's never been better. It's never been easier to look better in a population than now.
Yeah.
So you can go in with a half decent muscle mass, not even that low of a body fat, and you'll still stand out from an aesthetic point of view. Not that aesthetics are the health metric we're using, but it's just another surrogate marker. Well, that was a very, very off-the-cuff, random podcast. We should have ideally filmed the full one before, because we got into like a passionate.
I hope that people do take something from it, because I think it is important that we do have these conversations, because, like we say, we've obviously been in. We're seeing both sides to it. We're seeing the side of being in the NHS and being within the system, sort of like how it's being run, and what we're getting taught and everything, and. Just unfortunately, I think maybe it's even that, you know, things have progressed a lot more rapidly in terms of the 74% of people being overweight or obese. Maybe nobody accounted for that, and so it was like, oh, actually we haven't equipped the health system to be able to deal with that, which I think is a part of it.
It is. I want to say one thing about the NHS though. So I think a lot of people in the UK think that we're incentivized to do certain treatments. The NHS, from my understanding, is actually against incentivizing any treatments because they have a budget, I don't know, 200 billion, give or take. 94%, 95% of it goes to NHS England. And then of that, the more they spend on sick people, the less they have to utilise in other areas. Whereas if you look at the States and other private healthcare providers, then it is fully a capitalistic environment. So then that's where, I don't know, if you can diagnose more people with diabetes, then the pharmaceutical industry and all these companies that provide insulin, metformin, they capitalise on that. Whereas we, as a taxpayer, don't really benefit because that comes out of our budget. Ideally, we want a population of 65 million people who are healthy and don't require any intervention whatsoever.
I think it's just the actual issues that we're facing it's just so great. And the only thing that we can do, and I've said this before, is just advocate on our little area of, you know, of the internet for just people to live just more mindful. That's literally all it is. It's, you know, we're not saying to do what we've done, because I understand that that's probably extreme to most people, where, you know, you completely cut out everything and change your lifestyle. We enjoy it because we've got each other. But if you know,
and
if
that's
you're
the
doing
science at the moment. That's what we're being dictated by. If that changes in the next 5 years, then we reevaluate, and that's the whole point of science, is that you move the boundaries with it.
But just being more mindful, and, you know, obviously if people have got, or they're listening to this, or have got to this point and found our page, it sort of does show that people are wanting to know a bit more anyway. But yeah, I thought it was quite interesting. Like I say, I think it's important that we do bring up these things, because, like I say, we're on both sides of it. We're in the health system, but also we're trying to advocate for preventative health and trying to educate people on how, you know, they don't end up within or happen to be in the system, because it's not inevitable. You know, there are things that you can do, and we just hope that we can help as many people as possible to be that person who, you know, lives just a better life. It's not about living longer, or, you know, oh well, it is.
It is, but it's living a higher quality of life. And I said this the other day, is that I think people confuse the idea of living longer or living outside of a hospital as being a good quality of life. So we know a few people where they're not actively being treated for the moment, but they can't do anything. If you said, do you want to go and have a game of paddle, go for a hike, they couldn't do that. So in my opinion, that's a low quality of life. But because they're outside of an acute hospital setting or GP surgery, not requiring treatment, they class that as a success to their lifestyle, when in reality it's not fulfilling them in any way, shape or form. But my intention is to maintain I'm going to say lifestyle, but preventative measures before I need to go on treatments. There's probably going to come a point where I need to go on treatments, where my body, no matter what I supply it with, fuel, exercise, mobility, you name it, it's not going to be able to combat the genetic variability that I've got. Maybe even you've got in the future. We don't know what's going to manifest with you.
Well, yeah, I mean, we were saying today, weren't we? Both of us have never checked our LPA, which is one of the markers that we're doing on Byolete, and it'll be really interesting to see what mine is and what yours is, because I think from the book I was reading with Peter Attia called Outlive, his friend's cholesterol was fine, which my cholesterol's been fine, and it was only when he got a calcium score and then his LPA check that he realised that he had a really high LPA.
And he was really fit, healthy,
and he was really
active,
fit, 7% body fat. So that could be me, where I've only ever had my cholesterol checked. I've never had my ApoB, and so mine was fine. You know, it was not ideal, I would say. It's, you know, it's not high. It's just within the normal range of what we use, like as a surrogate marker. But my LPA could be really raised, and then that completely changes the game for me. And then it's like, okay, well, you know, what do I do, and what am I going to do to mitigate it and stuff? So,
of course, I mean, I use the word surrogate, and you just said it. Then I don't think I ever, only because a few people said, "Oh, they listen to the podcast sometimes," and I don't explain some words. So, surrogate marker, just before we end, is another. I was going to use another word, and I was going to say a proxy. So, it would be saying using someone's car as a surrogate marker to someone's wealth. So someone said, oh, well, they've got a Range Rover, they must be well off.
Yeah.
So we're using certain things, so like blood pressure, as a surrogate marker to heart health and all them things. That's what it means. It's another measure, isn't it? Or interpretation. I just wanted to say that because I get heckled sometimes when I go over, mainly by my dad. And he'll say, I don't have a clue what you're talking about. So I thought that's what surrogate marker means in medicine anyway.
But yeah, I think, do you want to wrap it up there?
Yeah, because I'll keep going on and on.
Yeah.
And I've got to edit this before it goes out.
But as always, thank you so much for listening. And if you've got to this point, then, that's amazing.
Congratulations.
Yeah, congratulations. Please like and subscribe to the channel because it really helps us. If you have any questions that you want us to answer, if you have any topics that you want us to speak about, let us know. If you have anybody you feel like would benefit from listening to this podcast, then please send it to them. And yeah, as always, we'll catch you with the next one.